Much. So that is a lot, right? We've covered a lot of ground there, but we actually, and we have lots of time for conversation and input. Um, and so please turn your table tent and actually either for the reactors or we can, if you have a specific comment or question for David or Catherine or Jerry as well. So, Frederick? Use your microphone. Can you do, and if when you do it for purposes of the recording, if you could state your name and who you're with and then use the microphone, please. Thank you.
Frederick Sassi with the National Governors Association. So excellent panel, excellent discussion, wonderful report. Congratulations to BBC for the terrific work and for the committee. Really excellent, excellent work. Just a few quick comments. One was that we are very, very positive and I think have been officially on the record about trying to elevate the Office of Duals. I think this is probably our #1 complaint that we get from our state leaders is, and it's not for bad reason, Medicare is a very different program from Medicaid. Medicaid's used to working with states to design state-specific solutions. Medicare's not. We need somebody in there who has the authority to make decisions across both programs. It's super important. Two, on the political side, just wanted to say this question of budget neutrality and costs to the federal government, and I think everybody in the room, I hope, is very aware of there's a massive financial, economic disincentive between states and the federal government. A state does something that saves Medicare money and they spend money, and Medicare does something that saves the state money, it costs them. So we really, I think, have to think very creatively about the ways in which states and the federal government on the Medicare side, the Medicaid side, can work together. And I think we believe really foundationally that there's massive savings there. And we have to think creatively about the way in which budget neutrality and savings will accrue in both directions. So do you want to make a response, Catherine?
Yes, in fact, that was something that we did hear a lot from states. And one of our recommendations was to allow states to share in a greater potential of the savings. First, we recommended that there be budget neutrality over the first 5 years, recognizing that both states and the plans and providers needed some flexibility to invest in the short term, particularly for the unmet need of homeless individuals and mental health services. And that is where it's needed, but also recognizing that states do need greater incentive to participate.
Absolutely. Three, just can't emphasize this enough. We are working right now across the country with state leaders who are building supervisor programs. On the Medicaid side, and I know on the Medicare side, it can look very different in some ways, but on the Medicaid side, and this is not the duals population, this is the pure Medicaid supervisor population, the role of the community is really the linchpin in all of this. And what we're seeing across the country, I just want to echo the wonderful comment earlier, we have to allow for payment and delivery mechanisms that elevate a community, tableau, group, whatever you want to call it, that can figure out what their community needs, the resources they have, and the ways in which they can work together. And sort of piggybacking off that point and to Catherine's point and also to Melanie's point, when we're making these sorts of new designs, either legislatively or programmatically, I think we should be agnostic as to whether or not this is payer-led or not. I think we should be careful about not designing mechanisms that rely on only a payer mechanism. So, we've seen wonderful examples where managed care companies are stepping up and other examples where it is not managed care led. And the best examples right now across the country, we've got, remember that in the Oregon CCOs, the Alabama RCOs, and now Washington State's ACHs, right? These are all new community-based organizations that are going to be responsible for driving a lot of this change. You have, in some instances, entities that are bearing risk, like in Alabama and Oregon, and in other entities, you have them running alongside of managed care organizations. So I think we don't know the answer to that question. We should stay agnostic. Housing, just wanted to make sure everybody knew we have been working very hard with a lot of people in this room. We have a new blueprint out for state leaders on how you integrate housing resources with healthcare resources, Medicaid, et cetera. It is available publicly on our website, and I think for anybody who wants to have a deep dive with us, we'd be happy to do it. It's super important. And then finally, Peter's heard me say this a million times. All of this rests on one thing, or at least one thing, which is data. And I think it's really tough for policymakers. It's the least sexy issue in the world. And policymakers just assume we change payment, we change delivery, and data will catch up, and it's not. And I think we as a country, as a community, need to really think about how we're going to aggressively attack the data question to create much better data systems on the Medicaid side. We have to put, I think, as much resources as we're putting in all of this to that question. So if we don't do that, it's not going to stop this, but it's probably going to slow it down by 10 years. So.
Thank you. Any reactions to?
A lot of great points. I'm going to react to the data piece first, just because it's something that spent a lot of time thinking about and very passionate about. While there's been a lot of great progress around electronic health record adoption for hospitals and physician groups, the challenge in this space is, of course, you have behavioral health providers and long-term services support providers and community partners who didn't get funding, don't have the tools, don't have the connectivity. So it is a major challenge, and I don't have an answer. I'm just agreeing with you that it's a challenge. One of the things that I hear about a lot, and I spend some time with as I'm sure a number of you do, with the plethora of mobile app tech folks, et cetera. I think that there is the possibility that if, as patients increasingly understand that they actually have the right to access their health information across settings, and technology evolves so that that can be done more and more easily through some type of mobile solution, I think there's some chance it may be faster and cheaper for that to be the path than to imagine us getting to a place where the hospitals, the physicians, the long-term care providers, the behavioral providers, and the social providers all A, have the technology, B, that it's actually integrated, and C, that even though they can share it, they actually do. So I think I'm more optimistic that we'll get there with a patient-driven model greater than a grand coordination across all sites of service.
I have a comment on data differently, which is I think we underestimate the power of implementation data that isn't RCT'd or quasi-experimental or comparison group, but that someone like Tim desperately needs. So when we talk about that the duals demos have been going now for 2.5, 3 years, what are we learning about the health risk assessment and who's doing it, and the care plan and how effective it is, and the interdisciplinary team and how's it working? And it's going to be largely anecdotal, but he doesn't get access to that. And so people at CMS can't make changes if they don't have something in front of them to say that the bet you made was a little bit off. So we got to tweak this here and there. And it ties in really well with the segmentation thought, because what we know is this population is very different. And so the more that the entities that are serving them can feed policymakers back information about subsets of this population so that we can refine all of these things across the board, the better, because they don't have access to that. They never will have access to that in the same way you guys do. And so I think people underestimate the power of what they're sitting on, even if you're only serving 10 people. It's still really important, and there's got to be mechanisms, better feedback loops that are out of a compliance discussion and into a how do we make this better discussion, and creating ways to do that I think could really move the field and help with this whole scale and adoption and all those things.
Thank you. We'll go to Mark and then Lauren here.
So just a couple of things, and I think these are really comments and, oh, right, Mark Miller, MedPAC. Since I've been called out twice, I thought everybody just already knew, okay? Thanks for telling me. So just a couple things on thinking about the policy world where things like this kind of leave the track. And I think most of this is comment as opposed to specific questions, although feel free. So I think what a lot of this is about is trying to define the models and the populations that might work and how that would all come together. But when it leaves here, it goes into the policy environment, and a lot of things start happening there. There will be, and I've seen, and all of you have seen this time and time again, an idea will move forward into the policy and environment, and what works is a very rigorous model. This population, this team, this kind of catchment area. Cast your mind way back to the beginning of the session where Eric was talking about his program. Then begins to be dissembled, and relaxed is probably a pleasant word for it, where people go, well, if a visit for this population is good, then it should be good for everyone. And then, of course, then the program, instead of being a proof of concept, it's a proof that it doesn't work because it begins to expand beyond what it's really intended to do. And it's, of course, really difficult because a point Melanie was just making is sometimes you want interaction and change to these ideas as people learn things in the field. So it becomes very hard to kind of judge how a program works. But the tension will be to dumb it down. The associations and all good intention, more for people. It's got to be good. The second thing to think through is I think that while you can find providers who are very forward-thinking, the Denver Healths and those types of folks, a lot of the provider community either isn't ready or doesn't want this kind of responsibility. So you look at this spectrum here and you say behavioral health and you say social factors, and they're saying, in Medicare, and again, Medicare Payment Advisory Commission, remember that? It's like 64 years of these events have happened, and now you're asking me to be responsible for it. And they don't want that response. Many, not all, many don't want that responsibility or want it measured in such a way that this group and these reports are really not thinking about. And so that, falls to people like me and other organizations to change the payment system and the measurement systems to say the ROI is shifting here. You need to think about that. But if the provider community is not going to take it up, then I think there's a bigger question of whether you're allocating resources to medical or allocating resources to social services, which is something that I think Jerry was getting at. I don't have my organized here, but the other thing I want to say about the tension in the legislative process, I think it's incumbent on organizations like MedPAC, like Commonwealth, like Peterson, like the Bipartisan Committee on the Hill to make sure that they understand and continue to think about this model works. If you start to relax all of this, then the model's not going to bring you the results that you think they're going to bring. A third concept, and then I just have one other thing, and I'll sit down. I generally don't like to talk at these things. It makes me very nervous. Is leadership. And I genuinely don't know how to talk about this and think about it. I try and work in a world of kind of, payment and measurement. But what you see, I feel like I see over my career, is this arc where somebody will produce a good model. And it makes sense. And the people who are driving it are actually having a success. And then you take that model and you scale and you go out. And that element is missing. And I don't know how to quantify it and make it happen. And so I'm appealing to other people out there. There's a psychology session for me, to think about that, because I believe it actually matters and I don't know what to do with it. And then just the last couple things on savings. I think there's a couple of things. One is there may be less out there than people think. So, sort of sizing expectations out there. We've been trying these things for years and years and years, starting off with Arnie calling me out, and saying we were talking about this for the last 10 years. There may be less there than you think. You're now in an environment where utilization has actually slowed down. And so measuring relative utilization is going to become more difficult. You're starting to bring in other things like behavioral health and social services, and so the counterfactual and the baseline that you judge it against, you really have to think through, because otherwise I think they're generally going to show that they don't affect anything. And then something Jerry said, remember, many of these models are incubated in very special environments. And then in my world, they show up and they go, let's do this in fee-for-service Medicare. And the lid gets blown off the thing and everybody is surprised. And so where they shouldn't be surprised, but where it's incubated and where you're taking it to matters a lot. That's it.
Reactors,
could
would you like to react to?
Could I just make one response? And Bill Hoagland, for those of you who know Bill Hoagland, he was staff director of the Senate Budget Committee for years and was at OMB, and he would probably be very upset to hear me say this, but I'm going to go for it. He's my boss, so. Yeah, it's just being webcast. We were very careful in this report to acknowledge that we don't anticipate savings in this model. At best, we're hoping for budget neutrality, deficit neutrality.
I'll start first with just the leadership comment that you made. I mean, I think if you think about these programs overall across where they're being run out of states together with the federal government, there isn't any kind of long-term plan around training up leadership and having people to be able to operate these programs. I mean, if you think about it, as a Medicaid director, running a $5 billion program with a staff of 170 people or something like that with no plan behind you for how you're going to train up those folks and get them to operate and do some of these great things that we all sit back here and think about. It's really impossible. And I mean, one of the reasons that you see all three of us sitting here probably, or in some ways, we were all involved with the Medicaid Leadership Institute that did help train us up in different ways. We all have great skills besides that. But there are some models, but I would say in your report or whatever you're putting together, it would be a key piece to try to include some of that funding or higher match rates for states who are able to invest in it. So right now we have Medicaid Leadership Institute being run by the National Governors Association and CHCS. We have the Academy in California being sponsored by a lot of different foundations, including SCAN and I think the Blue Cross Blue Shield Foundation there. And then we also have New Jersey, an academy in New Jersey, also being supported by foundations, but they're very spotty. And if a state doesn't have a huge foundation to support it like that, you don't see a lot of that growth. So I would maintain some idea around maybe incentivizing states who can come up with a little bit of higher matching rates. A lot of things are focused on 75-25 matching rates or 90-10 matching rates for these programs would be a way to make a recommendation. I know MacPac has looked at some of that, and it would be I think, important tool to use.
So I agree with all of Carolyn's comments, but just to kind of broaden a bit, I think that the conversation around opportunities around leadership, and you talked about some of the models that work, whether it's a particular plan that has an integrated model that's very effective, or a provider organization or community partner. I think it's a broader challenge to think about how do we both build leadership, but also ask ourselves, we talk a lot about what's the secret sauce for program X or Y in different contexts. And one of the things that I've observed is we don't always do the best job documenting, creating standard operating procedures, trying to really understand what is a repeatable process and what's not. And I think that, and doing succession planning. And so one of the things I think you see is that whether it's either, again, a small or medium-sized plan that, while run by a particular leader, is very effective at X and Y, then that person transitions and there's a gap. You see it on the community organization side. I think that thinking about how you partner with process engineers to come in and really understand what it is that your organization does and what's a repeatable or scalable process is really important. But I also think investing in leadership, both on the state agency side, I agree with everything that Carolyn said, but in some of these organizations, we saw in Massachusetts that we had some community-based organizations that were fantastic at a certain set of activities, but they had some real gaps in some of their approaches from a management perspective, or some real needs in terms of leadership development. And I think it's important to think about that as you're designing a number of these programs as something that's actually worth investing in, because if you think it's a model that's successful on a micro level that's worth scaling, it's actually worth doing that both on the investment side and also thinking about training over time.
Terrific. Let's go here, and then we'll go to Marcus.
So there's been a consistent theme throughout today's conversation. I'm Lauren from the National Partnership for Women and Families, around getting patients to better engage in these programs and how do you do it, and things that work and don't work. And we've primarily been talking about the engagement of patients at the point of care or in the service delivery. And I think one thing that hasn't been explored fully and something that can catalyze the success of these programs is in how patients and family caregivers and consumer advocates are involved in the governance and implementation of these types of plans, or the development of these plans. And I know that there are requirements for the duals demonstrations around consumer involvement in governance, and I know there's been a lot of resistance to that in some places. There are some other places like Camden, New Jersey, but also Massachusetts, that are doing it fairly well. But I do think that there needs to be a bit more acknowledgement of the fact that these are patients and families that are engaging in very different roles at the governance level, as well as in system or care process redesign, and that similarly, other stakeholders, they are engaging in different ways with patients and families. And I don't think that there's been adequate acknowledgement of the different roles and the type of support that it takes all of these stakeholders to engage in these new ways. And I don't think that states are availing themselves enough of organizations, whether they're state, local, national, like the National Partnership or Community Catalyst or UCAN in Ohio, that have expertise in this area and can help make the pathway easier to walk. And so I just want to put that out there because I think a lot, the tendency is to say, oh, there's this requirement to have a couple of consumers on this advisory body. And I don't want to say it's not important to have consumers involved in governance decisions in terms of fiduciary responsibility and how shared savings get redistributed in a community. But I think where the rubber meets the road really is in how are these plans designed? How does the care actually take place? And how can you involve patients in the improvement process? And all of this takes support, and it can be painful at times. And we hear providers aren't sometimes willing to be accountable for social needs and services, and we understand that sometimes they don't want to involve patients in this way. But I do think that if we can support them effectively in doing so, we're going to realize a power that we haven't yet, and one that will contribute to, I think, a better sense of shared ownership of these programs, how we can sustain them in individual communities, and how we can work together to solve some of the problems that we're challenged by today.
So let's take these two, to Marcus, together, two in the back, and take them together, and then we'll respond.
Marcus Escovedo with the John A. Hartford Foundation, and I just would echo Lauren's comment around consumer engagement. I think that is a really important point. A lot of the conversation has been really excellent in terms of important recommendations to think about, particularly around the alignment issues with Medicare and Medicaid. But I want to go back to Jerry, your presentation and the policy recommendations, and just point to a couple of areas that we at the John A. Hartford Foundation would recommend consideration. One, in terms of the care delivery and workforce and the need for more research on models of care. We would highlight the need for research specifically around the incorporation of family caregivers into those models. We heard from Ms. Humes-Butler today about them being such a linchpin to success, and so would point them out. We would also propose that they really should be considered part of the workforce considerations. We support the Elder Care Workforce Alliance that includes family caregivers as a critical component there. HRSA, through their Geriatrics Workforce Enhancement Program, includes family caregivers as part of their training and education efforts, and so I think that's something to consider. Secondly, on the quality measurement side, I think that another important piece, if we're talking a lot about care plans and meeting the needs of people with complex health and social needs, I think what we're really talking about is making sure that we're measuring what matters to these people, and that gets away from, as we've been discussing, a lot of the clinical measures. But I think what was missing was around goals of care. So there's some exciting work going on around how are we doing on documenting, eliciting, sharing patient health outcome goals and preferences, and how are we doing from the plans and provider side on goal attainment. So just offer that as recommendations.
Hi, Allison Hamblin from the Center for Healthcare Strategies. I'll try to be quick. I have a whole grab bag that I'd like to say, but I'll limit it. One is I really appreciate the really thoughtful discussion and opportunity to inform ongoing policymaking, particularly with respect to the dual eligible population. I also just want to mention for the Medicaid only population, which, and I shouldn't say that, it actually does include the dual eligible population as well, but Medicaid health homes offer another really important opportunity to be learning from implementation and to be informing and revising ongoing federal policy in this area. So Medicaid health homes, for those of you who may not know, is a mechanism that allows states to pay for care coordination and care management services and to target those efforts to particularly high need or particularly vulnerable populations with chronic conditions. There has been tremendous investment across many states across the country in these programs, and there's a huge opportunity to learn there from, again, kind of what's working, what policies might warrant revision and so forth, and I'm happy to share my short list of those with anyone who's interested. But I just wanted to flag that as a very scalable mechanism that many states have availed themselves of, and frankly, some states have have had to wind down their programs because of inability to meet short-term ROI expectations and so forth. And we should learn from those experiences and understand what we might tweak in terms of the policy and program requirements in order to make those more sustainable. And the other one I just wanted to flag, in addition to Medicaid health homes, is the new Medicaid managed care regs. In some cases are potentially real policy enablers of many of the things that we're talking about. But I think in some areas that are potentially particularly valuable to these conversations, like, for example, in lieu of services, there still needs to be some ongoing discussion and clarification as to sort of what the potential is and what might need to be clarified in order to take maximum advantage of some new flexibilities there. So.
Because none of us want to touch in lieu of services.
I do want to comment on the patient engagement piece, and we spent a lot of time on this when we were designing our duals demonstration, but also watching the design of these demonstrations across the country. It takes a lot of time, and it's a big investment, and it is absolutely worth doing. I have a lot of memories of really robust conversations in the same conference room that we would have similar conversations, although different ones with our providers. But creating space to hear from the patients, the members in that context, and their families, I think was invaluable. And you will not get the model right if you don't do that. And one of the things that I just observed as I was watching, and by no stretch did we get everything right in Massachusetts, and there are lots of lessons learned and opportunities for improvement. But we spent a lot of time on that. And as I've watched the demonstrations in some other states and people's approach to thinking about that, I do think that it's sometimes viewed as a burden as opposed to an opportunity. And so I think that as we kind of think about the next generation of models, continuing to emphasize the importance of it, but also trying to give people context and give them concrete examples around, we were headed down path X, we got feedback Y, and we changed our approach in this way. I think it's really important. I think you were alluding to, but in some ways, the need to actually think about how you create structure around that, right? Because people may need to take time away from the actual caregiving to come to that meeting. They may need help with transportation to come to that meeting. They may need support from organizations that will help to arm them with a fact base to actually be active contributors to a conversation. And so I think that those were all really important points. And then the last one, just based on some of the feedback around goals of care, I do think really important topic of conversation, and connecting it back to the measures conversation earlier, I think it's one of the areas where we're seeing some progress, but definitely additional opportunity for improvement there. And I want to read your health home papers, so I'll come and find you. I'll find you.
I can make one comment about the mega regs. That's what we call them, the mega reg. I get teased regularly at home about being a mega reg expert, but I think what we're hearing from state Medicaid directors is that they are going to eventually need some support. They need obviously some guidance from CMS, but eventually some support out there in terms of implementation. So as a health plan, we're looking across what we can do to try to help with some of that support, but there's going to have to be other entities that help as well. So I'll leave that out there, and that's a good point. Yeah.
We're going to have mega lunch now outside. So let me appreciate the reactors and the panel. So lunch is outside, and then we'll come back to our tables. What I'd love, and we don't have a formal program at lunch, but if you could think about what's one highlight that you've heard this morning, one thing that you think we're not quite getting right that we should think about differently, and then one gap. Just in your conversation, just, you don't do all of them, but just a little bit of framework so that we make sure we're getting some amazing feedback, and this is exactly what we wanted. But over lunch, if you keep crystallizing, one thing you think is the most important, something we haven't gotten right, and then anything that's a gap in our thinking so far. So thanks. We'll reconvene at 1 o'clock.